Hello, hi guys. Hi, hi everyone. I know. Welcome to this particular session where I'll be talking about the one-shot revision in surgery part 4. This particular session was due a couple of days back, but due to some of the other reason, I was not able to kind of take it. But I just decided to take it today. I don't know how much it's going to help you guys as the NEET PG is literally a couple of days from now. So without wasting any further time, let's kind of dive deep into it. So it's going to be a shorter session, let's say around 1.5 hours max. And what we are going to do, I'm going to cover it in the form of a kind of images, and I'll try to kind of add value to whatever I can. Okay, so yeah, let's kind of let's start. Let's start. No introduction, nothing. We'll not waste any further time. What we'll do is we'll just straight away start. Now, what you need to understand over here is, okay, so what is this? This is basically an X-ray. What you're basically saying is of a congenital diaphragmatic hernia, right? So what is this? This is what is your congenital diaphragmatic hernia. That's fine. So what is a congenital diaphragmatic hernia? That is what is a Bogdell-X hernia. Now, Bogdell-X hernia, what they basically many times ask you is that what is the location of this particular Bogdell-X hernia? So you can remember it by the kind of numbering BPL, that is Bogdell-X hernia is posterolateral, and it is basically more commonly present on the left side as compared to that of the right side. Now, very, very basic stuff. They might give you a clinical scenario, which is again very, very simple. They'll give you that there was a lady who delivered the baby, and at birth, what happens is that the patient is basically, like the child is basically having respiratory distress, okay, and then all these particular things and all, right? Now, all of you might be knowing that the bag and mask ventilation is absolutely contraindicated in this. So what you have to do is you have to pass a nasogastric tube and you have to decompress this particular stuff. Now, one thing which I want to ask you is surgery an emergency? So the answer is no. You have to intubate the patients, you have to stabilize the patients, and then once the patient is stabilized in, let's say, 24 to 36 hours or so, after that, what you basically have to do is you have to go ahead and operate on these particular patients. So these are the basic things which you need to understand. The most common cause of the death, or the most important prognostic factor in the patients with the congenital diaphragmatic hernia, is pulmonary hypertension. And what are the patients? Yeah, so all these particular things are there. Okay, now the next kind of thing which we're going to talk about is a GERD. Just give me a minute. Just give me a minute. Right. So, what is the GERD? GERD is basically gastroesophageal reflux disease. So, what happens over here is that due to some or the other reason, the intra-abdominal part of the esophagus, the length of that part basically reduces, and because of this, what happens? Acid is able to kind of reflux from the stomach into the esophagus. That's fine. So, the most important factor, there are various factors which are responsible for this GERD, but the most important factor is basically intra-abdominal length of the esophagus. So, that is what you need to understand. Now, obviously, the clinical features in this particular patient is going to be the heartburn. They're going to have the bad taste in the mouth and dental caries and all those particular things they're going to give you. Investigation of choice in order to diagnose which ERD is 24-hour pH monitoring. That's definitely there. Okay. Now, whenever you have a patient with the GERD, the first thing you basically do is you try to go ahead with a conservative management. You ask the patients to kind of reduce weight, don't take alcohol, all those particular stuff. But that, and yeah, the proton pump inhibitors and the H2 blockers and everything. If all those particular things fail, then you basically go ahead with the fundoplication. What is this particular fundoplication? So fundoplication basically means that the upper part of the like the stomach is basically wrapped around the esophagus, and then you basically what you call as that's what you basically do in that. So Nissens is basically 360 degrees. Then we have a door and we have a top it. So what is door? Door is the posterior or the anterior. Okay. So what you need to understand is, so just remember that there is door and the top it. Okay. So just please try to understand this. The door is posterior. So and top it is basically the anterior. So those particular things you have to kind of remember. Now the problem with the GERD is that it might lead to the esophagitis. What is the name of the classification system which you have for the esophagitis? It is a Los Angeles classification. Okay, so the Los Angeles classification is there for the esophagitis. What about the Barrett's esophagus? Okay, so if at all this particular insult continues, what is going to happen? The squamous epithelium of the lower end of the esophagus get converted into the what you call as a columnar epithelium, and that is what you basically refer to as a Barrett's esophagus. Now the problem with the Barrett's esophagus is that in this particular Barrett's esophagus, dysplastic changes can take place, which can ultimately lead to the adenocarcinoma. Now this is something which they can show you. They can just show you this, and they can ask you, this is basically used in the kind of treatment of what? Okay, so these are the magnetic beads which are basically used in the management of the GERD. So they are basically put in the lower end of the esophagus. When the food comes, food bolus comes, these particular magnetic beads are separated, and when the basically food bolus enters into the stomach, yeah, that's all basically you need to understand over here. So the magnetic beads can be used. The image has been introduced into your love and belly. So this particular image can be asked. So just remember, this is basically used for the management of the GERD. That's all fine. Now the Barrett's esophagus we just talked about. Very pretty basic question. It is a columnar metaplasia. Okay, so it's squamous epithelium converted into the columnar epithelium. The important part about all these particular things is what are you going to do? Now this is a clinical scenario which is important for all of you guys. Okay, so let's assume that there is a patient in whom you suspect that there is a what you call as a Barrett's esophagus. Okay, so what you do is you do an upper GI endoscopy and then you take a biopsy. Now what to do? Now once you take a biopsy, what are you concerned about? You're basically concerned about the dysplasia. Okay, so if at all you take a biopsy and if at all the dysplasia comes, do you take it as a face value? No, not really. What you basically do is you have to reconfirm it with some other independent pathologist. Okay, so you reconfirm the dysplasia types. First report you have got, you again have to reconfirm it with some independent pathologist. You have to kind of reconfirm. Now, once you have reconfirmed whether the dysplasia is there or not, okay, so if at all the dysplasia is not there, so first let's talk about the dysplasia is not there. Now, if at all the dysplasia is not there, then you can have a gastric metaplasia or you can have an intestinal metaplasia. Okay, now you can just go through this. So what you do is if at all there is a gastric metaplasia, then you repeat the upper GI endoscopy. If at all the length is less than 3 centimeters gastric metaplasia, you consider discharging the patient. So in other words, gastric metaplasia is a bit kind of on the benign side. Okay, so if at all there is a gastric metaplasia, this is the protocol which you follow. But in your mind, what you need to understand is the gastric metaplasia is like okay. So you don't order repeat upper GI endoscopy, especially if at all the length of the gastric metaplasia is less than 3 centimeters. If at all the length is less than 3 centimeters and if at all there is an intestinal metaplasia, over here also you have to perform an upper GI endoscopy with every 3 to 5 years. But if at all, let's say the length of the esophagus, like length in which you basically the maximum length of the esophagus which is involved is let's say more than 3 centimeters, then you have to repeat an upper GI endoscopy every 2 to 3 years. Now why on earth I am kind of emphasizing on this? Because they have asked you, right? If at all there is a patient for an upper GI endoscopy, you found that there is a metaplasia, when are you going to repeat the upper GI endoscopy? 2 to 3 years, 3 to 5 years. I hope you have understood this particular point. This is how you are going to get the answers. So broadly understanding gastric metaplasia less than 3 centimeters, discharge the patient. Intestinal metaplasia less than 3 centimeters, upper GI endoscopy every 3 to 5 years. Like intestinal or the gastric metaplasia, whatever it is, if at all the maximum length is more than 3 centimeters in that particular scenario, you have to repeat the upper GI endoscopy every 2 to 3 years. Okay, so this is what you need to understand. Now coming to the what you call as a forget about this. Okay, this is just like forget about this, not important for the MCQ point of view. All they are trying to say is if at all there is an indeterminate report, you basically do an upper GI endoscopy and you kind of repeat the biopsy and everything. So let's kind of forget it over here. Okay, then what you have basically is if at all there is a low grade dysplasia or a high grade dysplasia. So if at all you have a low grade dysplasia, then what you have to do is you have to repeat an upper GI endoscopy every 6 months. And if at all you have a high grade dysplasia, then you basically do this MDT and blah blah blah, all this particular stuff. But ultimately you have to basically perform the ablation. So you with the help of an endoscope, you have to ablate this particular kind of high grade dysplasia. Okay, so this particular protocol is important, again given in your recent edition of Love and Berry. So very important. Gastric metaplasia less than 3 centimeters, nothing doing. If at all intestinal metaplasia less than 3 centimeters, upper GI endoscopy every 3 to 5 years. Whether it is intestinal, whether it is gastric, if at all the metaplasia is more than what you call as the 3 centimeters, repeat an upper GI endoscopy every 2 to 3 years. Okay. Then what we have is a low grade dysplasia. If at all there is a low grade dysplasia, repeat an upper GI endoscopy every 6 months. And if at all there is a high grade dysplasia, then you have to go ahead with an endoscopic ablation of that. Okay. So that is what you need to understand over here. Okay. So this is the management protocol, what you have for the dysplasia. Now coming to the hiatus hernia. What on earth is this particular hiatus hernia? Hiatus hernia is basically when the part of the stomach is basically going up into the thoracic cavity. Now this can be broadly of two types. It can be a sliding hiatus hernia or it can be a rolling hiatus hernia. What do you understand by the sliding hiatus hernia? In this, like the gastroesophageal junction is basically pulled up. Okay, so if at all the gastroesophageal junction is basically pulled up, what is going to happen? The intra-abdominal length of the esophagus is going to go down, and that is why the GERD is going to happen. And that is the reason why sliding is type 1. So like the gastroesophageal junction is basically pulled up, and over here what you basically find is a GERD. So if at all there is a patient with a GERD, what you first do is conservative management. If at all that fails, then you go ahead and do a surgery. That's all fine. What about the type 2 hiatus hernia? This is the rolling or the paraesophageal. Now in this, what you need to understand is that the gastroesophageal junction is at the normal location, but the stomach is basically like the part of the fundus of that particular stomach is basically going into the thoracic cavity. Are you understand my point? So this is what is referred to as your rolling hiatus hernia. Right. Now, in this particular rolling hiatus hernia, so this is what is a rolling hiatus hernia. That's fine. Okay. Now, G junction is basically normal and there is a no GERD in these particular patients. So that is what you need to understand. What about the type 3? Type 3 is basically the type 1 and type 2. Type 4 is basically all these particular things. Along with that, some intra-abdominal organ is also going, for example, liver or the transverse colon or something like that. I hope you're able to understand this point. Type 1, type 2, type 3, type 4. These are the 4 types of the hiatus hernia, which you basically need to understand. Now, the problem with this rolling type of hiatus hernia is that, so what is happening in this particular rolling hiatus hernia, that let's assume that this is a G junction that is at the normal location, but the part of the fundus is basically going up, and over here what you have is a diaphragm. So in this particular part of the fundus which has gone into the thoracic cavity, here the ulcers can develop, which are basically called as a Cameron's ulcer, because this particular part of the fundus which has basically gone up is at a risk of undergoing a necrosis and perforation and all this particular stuff. And that is the reason why in these particular patients what you basically have to do is definitive surgery. But in the type 1 hiatus hernia, you can try the conservative management. If it all that kind of helps, it's fine. If doesn't, then you have to kind of go ahead and what you call as I hope like then you have to perform a fundoplication. Okay, right. Then we have a motility disorder. What is a what you call as a classification system for this particular motility disorder? We have a Chicago classification. What is the name of the classification? Endoscopic classification for Barrett's esophagus. This is again important. There's something which is called as a C and M classification. So what is C? C basically tells you that how much amount of the length of the esophagus there is a circumferential involvement of that particular Barrett's esophagus, and M basically means maximum length. So how much of the entire, like what is the maximum length where the whatever the Barrett's esophagus is kind of involved. Are you understand my point? So C and M classification is for your what do you call it, the Barrett's esophagus. Los Angeles classification was for your esophagitis, and the Chicago classification is basically for your motility disorders. Okay, now what is this particular what do you call as an like achalasia cardia? What is an achalasia cardia? Achalasia cardia basically means that there is a whatever, the lower part of the esophagus is not able to relax, and because of that there's going to be the dysphagia. Very basic question. Dysphagia is going to be more to the liquids as compared to that of the solids. Okay, ultimately the solids are going to kind of face this particular problem, but it is going to be primarily like first it is going to be for the liquids. That's all fine. Now the problem is going to be in the clinical scenario that they're going to give you that the fullness in the kind of mediastinum and like aspiration and lung like pneumonitis and all this particular stuff that's going to be kind of given in your what you call as a clinical scenario. Now the first investigation which you basically do is your barium studies, and then the investigation of choice is basically your manometry. In the manometry, that is what is the investigation of choice. Now based on whatever the pressures you basically get, you divide it into type 1, type 2, type 3. Now what you need to understand is in the type 3 what is there is a entire length of the esophagus is basically contracting. So that is what is called as a like, so the like we will talk about the Heller's cardiomyotomy. The benefit of the Heller's cardiomyotomy is going to be maximum in the type 3, because here that there is a at least esophagus is trying to contract. In the type 1, what you need to understand, the pressure which is going to be generated is going to be much lesser than the 450. So ILR is going to be the kind of same in all these particular three. The common thing is going to be that lower esophageal sphincter is not able to kind of relax, so ILR is going to be more than 150, but the like the DCI is basically going to be less than 450 in the type 1, and the type 2, type 3 it is going to be more than 450. So that is what you need to understand over here. Now what you need to understand over here, this is, I'm pretty sure that you guys know about this. This is a very simple image, which is basically your on the barium swallow, what you're basically going to get is the bird's beak appearance and the rat tail appearance and all this particular stuff. Okay, so gold standard, no. Satija, for achalasia cardia, the gold standard is definitely a high resolution manometry. Based on the manometry, you basically diagnose that. Biopsy has not that much of a role in this. Okay, right? Okay, got it. Okay, right. Okay, now what about the management? So management is basically the first you can go ahead with the drugs, there is the calcium channel blockers and all those particular stuff you can try, which might help you kind of relaxing the lower esophageal sphincter, but many times they are not that helpful. Now in the endoscopic management, you can have a balloon dilatation or the Botox. Now are these kind of helpful? Yes, they are helpful, but the problem with these particular stuff with the endoscopic management is that this has to be kind of repeated every 6 months. Okay, every 6 months it has to be kind of repeated. That's what you need to understand. Heller's cardiomyotomy, that has always been the kind of a treatment of choice. And once they had asked, this poem is basically used for the treatment of what? So poem is basically used for the treatment of what you call, okay, so let's kind of go through the images. This is what is a injection of the botulinum toxin and everything. What is this? This is a balloon dilatation. These two procedures have to be repeated every 6 monthly. What is this? This is a Heller's cardiomyotomy. Here what you need to understand is the muscle is cut and then the mucosa is basically allowed to pop out. Okay, so the mucosa is basically allowed to pop out. And what is this? This is what is a poem. What is this poem? Per oral endoscopic myectomy. So this is what is a poem procedure. Okay, so here what you basically do is you go in with an endoscope, stethoscope and you basically cut the muscle layer. So this is what is a Poem's procedure. So that is what you need to understand over here. Okay, now this is an X-ray which has been given to you. What is the diagnosis over here? So the diagnosis over here is your Zenker's diverticulum. Okay, so Zenker's diverticulum. Now this is again a very important topic. So what you need to understand over here is Zenker's diverticulum. So what happens in this particular Zenker's diverticulum is that there is a like the coordination is kind of a problem between the thyropharyngeus and the cricopharyngeus muscle. The cricopharyngeus doesn't kind of relax. So what is going to happen? The pressure inside the esophagus is going to rise, and because of this, what is going to happen? The mucosa is going to kind of bulge out. Okay, so the mucosa is basically going to bulge out. So this is the type of your Pulsion diverticulum. Okay, so because of the increased intraluminal pressure, the mucosa is basically pushed out. Now, over a period of time, when you basically eat food, what is going to happen? The food is going to get accumulated in this particular the pouch, and because of this, over a period of time, the food get kind of degraded, and because of this, what you need to understand, there's going to be halitosis. That is a bad odor in the kind of a bad odor in this particular patient. Okay, so the halitosis is going to be there. Second thing, what you need to understand is the aspiration and the lung abscess. All those particular complications are going to be there. Investigation of choice to diagnose the Zenker's diverticulum is a barium swallow. Here you are able to appreciate that there is this particular diverticulum which has been kind of there. Okay, now for the management, what you need to understand is that if at all it is very small, less than 2 centimeters, then you can go ahead with a cricopharyngomyotomy. So once you cut this particular cricopharyngeus muscle, the strength of that particular muscle is basically going to go down, and because of this, what is going to happen? If at all there is a small diverticulum, what is going to happen? That particular is going to kind of recede back. If at all, let's say it was 2 to 5 centimeters, then you can perform a diverticulectomy, or sorry, diverticulopexy, or what you can perform is suture diverticulopexy. That is, you basically make this particular diverticulum anti-gravity. Okay, so then you suture it like in the anti-gravity position, or you can perform something which is called as a Dollmann's operation. Dollmann's operation. Okay, now this has been asked to you. Dollmann's operation is basically used for what? So this is basically used for your Zenker's diverticulum. Okay, so yeah, okay, so it is basically used for your Zenker's diverticulum. Now, what is the Delorme's procedure? Where does this particular Delorme's procedure, this is basically for what? So the Delorme's procedure is basically for your rectal prolapse. Okay, Dollmann's procedure is basically for the Zenker's diverticulum. Delorme's procedure is basically for your rectal prolapse. Do not get confused between these, and if at all it is more than 5 centimeters, then you go ahead with a diverticulectomy. Now you have a carcinoma esophagus. It can be either squamous or adenocarcinoma. So what are the risk factors for the squamous cell carcinoma? So aplasia cardia. Okay, then you have what you call as esophageal strictures, or the anything which is basically going to reduce the peristalsis, and it is going to increase the food staying inside the esophagus. That is what is going to be the risk factor for that. Adenocarcinoma, the major risk factor is basically what you call as your Barrett's esophagus. Okay, so that's what you need to understand. Now, in the squamous cell carcinoma, do not forget this corrosive acid injury. This has a very high risk, 1000 times increased risk of squamous cell carcinoma after the corrosive acid injury. Very important. Okay, most common overall is basically is like this, like in the lower part of the esophagus, which is basically an adenocarcinoma. Now, this is definitely a barium's kind of an image which you're going to get. So here, if at all, if I ask you rat tail appearance is seen in what? So rat tail appearance is basically not characteristic of your carcinoma esophagus. Please remember this, okay? Rat tail appearance is basically a characteristic of your aplasia cardia. Over here, what you basically get is an apple core appearance with the shouldering of the esophagus. So what on earth is this particular apple core? So it assumes that like somebody has kind of eaten this particular apple, and whatever the core has been kind of left behind. So this is what is called as an apple core appearance, and this is what is called as a shouldering of the esophagus. So these are the two things: shouldering of the esophagus. So that is what is the diagnostic thing of. Now, investigation of choice to look for the like the T and the N stage. So T and the N stage is basically your endoscopic ultrasound. EUS, endoscopic ultrasound, is the investigation of choice for your T and the N stage. Okay, so that is what you need to understand over here. Now, this is what is an image. This can be shown to you. So please try to understand there are alternative white and the black. So what you basically called as a hyperechogenic and hypoechogenic. So these black, which is the hypoechogenic, they are basically caused because of what? So whatever the layer is going to contain the muscle. So muscularis mucosa and the muscularis propria. Okay, so these are the two layers which are going to be hypoechogenic. Rest all, like so mucosa, submucosa, serosa, like all those particular things are going to be your what you call as your hyperechogenic. Please remember this point. Okay, so some muscularis mucosa and the like muscularis propria, these are the things which are going to be hypoechogenic. Okay, so please remember this important. Okay, right? Okay, now these are the simple one-liners which they ask you. What is the presenting feature? It's always going to be the dysphagia. The characteristic thing of the carcinoma esophagus is that the dysphagia is basically more to the liquids. That's like it is going more to the solids, like earlier to the solids as compared to that of liquids. That's all fine. Then what we have is the first investigation is always going to be the barium swallow, and yeah. So I'm really sorry, serosa. It is basically the like the adventitia. Okay, so that is what you need to understand over here. So like the mucosa, submucosa, and the adventitia. So that's what you need. So try to understand what I was trying to tell you was, Satija, is if at all there is a muscle there. Okay, so muscularis mucosa and the muscularis propria, those are the ones which are going to be hypoechogenic. So it is just for the esophagus that the serosa is not there. But what you need to understand, let's assume if you talk about the other parts, for example, even in the rectal carcinoma, also what you have is a transrectal ultrasound. So in the transrectal ultrasound, you basically try to look for the like the T stage and everything. So like what is the depth of the invasion into like the layer and everything. So there you basically have to consider. So anywhere, whenever you're performing an endoscopic ultrasound or like a transrectal ultrasound or something, so mucosa, like muscularis mucosa and the muscularis propria, those are the ones which are going to be hypoechogenic. Rest all the areas are going to be hyperechogenic. Wherever there is a muscle component, that is what is going to be the hypoechogenic. Okay, right. Now these are the one-liners which you basically have. So what we have is a dysphagia then. Okay, so presently which is going to be the dysphagia that we talked about. The first investigation is always going to be the barium salve, where we're going to get this particular apple core appearance and the shouldering of the esophagus and everything. Then we have an endoscopic biopsy, that is what is going to be an investigation of choice. TNN stage EUS, I told you, overall staging is all fine. Now what you basically do in the esophagectomy, you basically remove this particular esophagus, you throw it off, and then you have to replace it with something which is basically called as a conduit. Okay, so what on earth is this particular conduit? Conduit is basically the replacement for the esophagus, because after you eat the food and something like that, that food has to kind of reach to the stomach and the distal part of the intestine, right? So what is the preferred conduit after the esophagus, like after the whatever the excision and everything? It is the stomach. Stomach is basically the preferred conduit. Okay, so let's not go into the surgeries and everything, that's all fine. So what is the preferred conduit? Stomach is basically the preferred conduit. Okay, so this particular stomach is based on what? So this is based on either the right gastric artery or the right gastroepiploic artery. If at all both are given in the options, what are you going to choose? You are basically going to choose a right gastroepiploic artery. Okay, so that is what you're going to kind of choose. Okay, if at all both are given in the options. Okay, now if I just give you a question, I want you guys to answer. I'll obviously tell you the answer. I'll not wait for you guys to answer, but I'll just kind of tell you that. Okay, so let's assume that there is a patient. We just talked about the corrosive acid injury, right? It can lead to whatever the carcinoma of the esophagus. Okay, squamous cell carcinoma. So there's a patient who basically had a corrosive acid injury, let's say 10 years back. The patient survived, and now the patient is basically coming to you with a carcinoma of the esophagus, squamous cell carcinoma. What you did was you performed a esophagectomy. Now, what is the preferred conduit which you're going to use over here? So please think for let's say 2 seconds. The answer to this is colon. It is not the stomach. Okay, why? Because what you need to understand, when you basically drink, like whenever that particular patient would have drank that particular corrosive acid, it would have come in contact with the esophagus for let's say a couple of seconds. But what you need to understand is that it basically went into the stomach and it remained in the stomach for a couple of hours. So it would have caused the scarring and the contracture of the stomach. Okay, so which you basically don't want. Okay, and that is why the stomach cannot be used in this particular scenario. I hope you have understood this particular point, guys. Okay, so whenever you're dealing with the patients with a corrosive acid injury, in these particular patients, what is the preferred conduit which you're going to use? It is going to be the colon. It is not the stomach. I hope you have understood this point. Please do remember this. It is an important kind of a thing. Okay, now what is this? This is what is a self-expandable metallic stent, which is basically used as a palliative measure. If at all there is a metastatic carcinoma esophagus, as a palliative measure, what you basically use is a self-expandable metallic stent. Then congenital hypertrophic pyloric stenosis. I know you would have read this hundreds of times. I'll just quickly kind of revise it. So first born male child, 3rd to 4th week. Okay, so it is not like this has been answered. Presentation is when it is around 4th week. Okay, so patients are going to come to you with what you call as a non-bilious vomiting and the palpable colon like lump and visible. Okay, palpable olive-shaped lump. Peristalsis is going to be visible. Okay, from the left to the right, and all those particular left to the right is again important. Investigation of choice is an ultrasound. So on the ultrasound, what you're going to see, you're basically going to see what? That the length. Okay, if at all the length of the pylorus is basically more than 16 millimeters, and if at all the width of the pylorus is basically more than 4 millimeters, this is what is diagnostic of your congenital hypertrophic pyloric stenosis. All those particular stuff is fine. Now the complication is again very, very important over here. So what you basically get is a hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Now again, if you, I'm pretty sure that you guys know this. If you don't, please do remember this. Very, very important. So what is a metabolic kind of a thing over here? It is a hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Will you operate on this particular patient immediately? No, not really. You'll have to first resuscitate the child, because the child has come to you with whatever the non-bilious vomiting and everything. So the child will be in the state of dehydration. All these electrolyte abnormalities are there. So you have to first resuscitate the child, and then you'll have to perform this Ramsted's pyloromytosis. tracheotomy. Now, my question is, how do you resuscitate this particular child? What is the fluid of choice in order to resuscitate this? If you say normal saline, it's absolutely wrong because normal saline doesn't have potassium. If you say Ringer's lactate, again, it's wrong because in the Ringer's lactate, what you need to understand, there is a lactate. Okay, so what happens to this particular lactate? The lactate basically gets converted into the bicarbonate in the like in the liver. Okay, and already the patient is in the state of alkalosis, so you don't want more bicarbonate in your body. So the fluid of choice in these particular patients is normal saline plus the potassium supplement KCl. So normal saline plus the KCl, that is what you basically have to use for resuscitation in the patients with congenital hypertrophic pyloric stenosis. This is an important question. You have to kind of understand this particular point. Okay, so I've covered okay, I hope you've understood. I will take an opportunity to talk a bit about your Ringer's lactate. So what you need to understand about the Ringer's lactate, it is a lactate, okay, lactated Ringer. So what happens to this particular lactate? Lactate is basically converted into the bicarbonate into the liver. So we just saw that it is basically avoided in this particular scenario because already if at all the patient is in the state of metabolic alkalosis, you will not use Ringer's lactate. Another is if at all there is a patient with a hepatic failure, Ringer's lactate is again kind of not used. Okay, I hope you have understood this particular point, right? Hepatic failure, Ringer's lactate is not used. Now, what we have is this particular H. pylori, just kind of go through this. So that's all fine, and yeah. So this is basically the gram-negative bacilla, Cocobacilli, Lupfutocus, all those particular stuff. Let's talk about the tests. Okay, tests. So if I ask you the investigation of choice to diagnose the patients with H. pylori, what is an investigation of choice? So investigation of choice to diagnose the patients with an H. pylori is you have to do an upper GI endoscopy, you have to take a biopsy, and you have to send it for the culture. Now, please do understand this particular point, very, very important. Okay, no, it is not the ureas. That's what I'm trying to talk to you about, Recordnet. Okay, so what ureas? Urea breath test or the rapid urease test? What are you kind of talking about? So please try to understand over here. Okay, so investigation of choice is 100% kind of sensitivity of the investigation is that you have to do an open endoscopy, take a biopsy, send it for the culture. That is what is the investigation of choice. 95% sensitivity specificity is basically for the rapid urease test. What do you understand by the rapid urease? Rapid urease is basically you go in, you basically take the biopsy, you put it on the slide, and you put the whatever the urease enzyme. This particular bacteria has a urea. You put the urea. This particular bacteria has a urease enzyme. So that basically kind of gives you the result. You understand my point? So the rapid urease test is basically not like the investigation of choice. If they have not given you this particular kind of biopsy with the culture, then you can go ahead with that. Okay, but please to understand biopsy with culture. If at all you have, if they have given this is obviously a better investigation in order to kind of diagnose the patients with an H. pylori. Now, what you need to understand is that once you have diagnosed the patients with an H. pylori and everything, you're going to give them the whatever the anti-H. pylori kit and the therapy and everything. And based on this, what you need to understand that the patients might be treated. Now, after you have done with the whatever the medical management and everything, you want to see whether the patients have whether that particular H. pylori has got eradicated or not. In order to look for the eradication, then you will have to perform a couple of tests. So what are the tests which you have to perform for to look for the eradication? For the eradication, what you basically perform is a urea breath test. Okay, so urea breath test. Now the another test is basically to check for the H. pylori antigen in the stool. If at all they have given you this H. pylori antigen in the stool, that is the better kind of a test. Okay, so please do remember. Okay, if at all they have given you the H. pylori antigen in the stool, that is what is a better investigation in order to look for the eradication. But I hope you have understood this particular point, guys. Okay, so I'll just summarize. Investigation of choice to diagnosis, biopsy with the culture, and investigation of the best investigation to look for the eradication. What is this? This is basically what you call as your so investigation to basically look for the eradication is what this urea breath test. Okay, so the urea breath test, but if at all they have given you the antigen and or the H. pylori antigen in this tool, that is what is the better answer. Usually they will not give that, and then you'll have to mark this particular urea breath test. Okay, so I hope you have understood this particular point. I hope I have not confused you, but these are the answers, guys. This is one of the confusing parts of this particular H. pylori. I hope you have understood this particular point, right? Now the problem with H. pylori is that it is associated with so many kind of diseases and all. That's all fine. It basically is associated with the type B gastritis. What about this particular type A gastritis? What is this particular type A gastritis? Type A gastritis is basically autoimmune gastritis. So that is what is basically going to lead to your B12 deficiency and everything. Type B gastritis, how do you remember it? B is for bacteria, so which is H. pylori, right? A is for autoimmune, that is what is the antibodies against the intrinsic factor and everything. So that's what you need to understand. Now the peptic ulcer disease, gastric ulcer, all those particular stuff are fine. Now what is the most common site for the peptic ulcer? The most common site for the peptic ulcer is the duodenum. It is not the stomach. Okay, but then what we have is the Johansson's classification. Now what is this particular Johansson's classification? classification? Johansson's classification is basically the classification of the ulcers of the stomach. Okay, now this is the 5 types and they are very, very important. What is the type 1? Type 1 is basically located at the incisura angularis, okay, which is the most common type. So this type 1. Type 1 is the most common type, and this is the one which is basically located at the incisura angularis. Okay, I hope you have understood this particular point, right? Now this is not associated with the acid secretion. Okay, so increased acid secretion is not the cause for your type 1 kind of a gastric ulcer. Then we have a type 2. Type 2 is basically what? It has a pre-pyloric as well as the pyloric. Okay, so it has a 2 ulcers. One is basically in the pre-pyloric, one is in the pyloric region. What about the type 3? Type 3 is basically located at the the antrum of the stomach or whatever, the pre-pyloric or something like that. What about the type 4? Type 4 is basically located in the on the lesser curvature. What about the type 5? Type 5 is basically NSAID induced. Okay, so this is basically NSAID induced. Okay, so I hope you have understood this particular point. Type 1 is the most common. So a couple of questions which you definitely have to remember is type 1 is basically the most common, located at the incisura angularis. Type 2 is basically pre-pyloric as well as the pyloric. Type 3 is basically in the antrum or whatever the pyloric, and then type 4 is basically on the lesser curvature. Type 5 is basically NSAID induced. Now, which of these are associated with an increased HCl secretion? Type 2 and type 3 are the ones which are associated with an increased HCl secretion. Very, 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 very important. Okay, I hope you have understood this particular point. And that is the reason why the vagotomy is something which is needed whenever you are basically performing, whenever you are basically managing the type 2 kind of a gastric, type 2 and a type 3 gastric ulcer, you have to basically perform what you call as a vagotomy. Now, what are the complications? So, hemorrhage is the most common complication. Duodenum. The problem with the duodenum ulcer is that if at all it basically ruptures anteriorly, it will lead to the perforation. But if at all there is a posterior perforation of the duodenal ulcer, it will lead to the bleeding. And the cause of the bleeding will be gastroduodenal artery. Gastroduodenal artery is going to be the source of the bleeding if at all the duodenal ulcers basically perforate posteriorly. Okay, then the perforation, that is the most common complication of the gastric ulcer, and all those particular things are fine. Gastric outward obstruction, all those particular things. Let's go there. Okay, now vagotomy, forget about it now. At this point of time, let's not cover it. Okay, now gastric ulcer, like we talked about the type A, type 1, type A and the type B gastric ulcers and everything. That's we talked about. Meniere's disease is again one of the risk factors. FAP, BRCA, all those particular things are there. Okay, now let's talk about the classification system. So what we have is a Stewart classification, we have a Japanese classification, we have a Borman's classification. So what about the Stewart classification? This is the GE junction classifications. Okay, so it is basically 5 centimeters above the G junction, 1 to 1 centimeter above the G junction, 1 centimeter above the G junction to 2 centimeters below the G junction, 2 centimeters below the G junction to 5 centimeters below the G junction. So this is type 1, type 2, type 3. Type 1 and type 2 are basically treated like the esophageal cancer. Type 3 is the one which is basically treated like the gastric cancer. Then what we have is Japanese classifications. Let's not go into the details of it, but the Japanese classification is basically for the early gastric cancer. Okay, so and that's what you need to understand. So here type 1, type 2A, type 2B, you can perform the local excisions like the extramucosal dissection, those particular things can be performed. Type 2C and the 3, you will have to perform the surgery. Then we have a Borman's classification. What you need to understand, sometimes they ask you this, okay, linitis plastica is what? So linitis plastica is a type 4 Borman's classification. What on earth is this particular linitis plastica? So linitis plastica is basically the appearance of a leather bottle stomach. So what happens is that it is so much infiltrative, predominantly infiltrative. So what is going to happen? The entire stomach is going to become like a leather, very, very hard and the tough structure like a leather. That's what you need to understand over here. So type 1 is basically polypoidal, then ulcerative, ulceroproliferative, and predominantly proliferative. So that is what you need to understand as a type 4. Now, the most important of all these particular classifications is this Lawrence classification. So this is basically the histopathological classification. This is very, 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 very important. Okay. Now you basically have this as a intestinal and the diffuse. Now what do you understand by the intestinal and the diffuse? So in the intestinal, what you need to understand is that if at all you in your mind, if I ask you that, tell me a characteristic description of a patient with a gastric cancer, what are you going to tell me? That okay, this is an elderly patient, it is more common in the males, and it is going to be okay. So like let's talk about what is the risk factor. Like predominantly, what is the risk factor for the gastric cancer? It is an H. pylori, which is basically your what you call as an environmental risk factor. It is more common in the males. It is an elderly population. It is going to be occurring most probably in the distal part of the stomach. So this is the characteristic description of the CA stomach which you're going to give me, right? Absolutely right, right? So these are all the points of our intestinal. What about the diffuse? They are absolutely opposite to it. So diffuse is the one which is basically the familial. It has a familial risk factor, more common in the females as compared to that of the males, occurring in the younger age group and the proximal part of the stomach. So what is the familial risk? So there is a genetic, like the E-cadherin genetic mutation. So please remember over here, yeah, E-cadherin mutation is the one which is basically associated with your diffuse type of the gastric cancer. Very, 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 very important. Now the second thing which you might screw up in your exams is signet ring cells. Okay, so if you know, it's great, but if you don't, please remember this point. Now if you don't know, in your mind, in the exam, what is going to go is that, you know, signet ring, it means that the empty cell, it might be in the intestinal type. Intestine has the mucosa and everything, right? So if at all you try to apply the logic in your exam, you'll go wrong. So but please remember, signet ring cells are basically seen in your diffuse type of the gastric cancer. Very, 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 very important. Okay, I hope you have understood this particular point. Now what about the metastasis? Intestinal type is basically predominantly lymphatic metastasis. The diffuse type is basically having a predominantly hematogenous metastasis. What is this? Hematogenous mets. Okay, so what is this? This is going to have your predominantly hematogenous metastasis. Okay, so I hope you have understood this particular point. So this is a Lawrence classification, histopathological classification. It's very, 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 very important. Okay, now associations of the gastric cancer: Systematic Joseph nodule. All of you guys know that. Periumbilical kind of a lymph node metastasis. Systematic Joseph nodule. Krukenberg's tumor. Bilateral perimenopausal superficial tumor. No tumor inside the ovary. So how do you distinguish the Krukenberg's tumor from any other bilateral ovarian tumor? If at all there is a primary ovarian tumor, it is going to be the tumor inside the ovary. Now how do you kind of know that? So with the help of an ultrasound and the CT and everything, you get to know whether it is a primary ovarian tumor or not. In the Krukenberg's tumor, what is going to happen? There's going to be the superficial deposit over these particular ovaries, and that is what is the Krukenberg's tumor. It can be bilateral transcoelomic spread of the gastric cancer. Then Blummer's shelf is there. Virchow's node, that is a Trozier sign. Now this is important. What is a Trozier's sign? Trozier sizes left kind of supraclavicular lymph node enlargement is the Trozier sign, where Trozier sign, which is basically what you call as a Virchow's node. What is a Trozier sign? Trozier sign is basically the carpopedal spasm in the patients with the hypocalcemia. And what is Trozier syndrome? Trozier syndrome is basically the migratory superficial thrombophlebitis which you get in the patients with, let's say, pancreatic cancer and all this particular stuff. So please remember, Trozier's sign, Trozier sign, and what we have is a Trozier syndrome. Trozier syndrome is basically in the pancreatic cancer. Then Irish node and everything, forget about it. Irish node is basically lymph node in the axilla, forget about it. Investigation of choice to diagnose is definitely upper GI endoscopy with a biopsy, and the investigation of choice for the T and N stages and endoscopic ultrasound. Now when you talk about the surgery, so whenever you have a patient with the gastric cancer, surgery, yeah, you have to kind of do a partial gastrectomy or whatever, the complete gastrectomy or something like that. Along with that, you have to remove the lymph nodes. So what are the lymph nodes which you basically remove? So D1, D2, kind of stations of the lymph nodes which you have to kind of remove. These are important. Sometimes they ask you. So let's kind of revise this. First 6 are very, very simple. They're basically present around the stomach itself. So right and the left, whatever the pre-pyloric, right and the left basically, not the pre-pyloric, right and the left kind of a fundal. Then what we have is along the lesser curvature on the greater curvature, and then the right and the left pre-pyloric or something like that. Okay, you understand my point? So right and the left fundal along the lesser, along the greater curvature, right and the left pre-pyloric. So this is what is constituting the D1 kind of group of lymph nodes. What is the D2? D2 is important. So whatever the blood supply to the stomach is there, I'm pretty sure that you guys know about the celiac trunk and the branches of the celiac artery and everything. Very, very important question. Okay, so based on that, what you have is this particular D2 group of lymph nodes. So what is these particular D2 group of lymph nodes? So what are the direct arteries from the celiac trunk? What we have is a left gastric artery, then the common hepatic artery, and the splenic artery. Out of these, the left gastric. Okay, so the left gastric and the common hepatic, they have the lymph nodes. So 7th is basically the left gastric, 8th is basically the common hepatic. Then the 9th, there is a bit of a trick. So 9th is basically at this particular celiac trunk. 10th is basically at the splenic hilum, and the 11th is basically along the splenic artery. So splenic artery is the one which is basically ignored in this. Okay, so I hope you have understood this particular point. First 6, right and the left, what you call as a fundal. Then we have along the lesser curvature and the greater curvature, right and the left pre-pyloric. Okay, so this is the D1 group of lymph nodes. What about the D2 group of lymph nodes? D2 is basically left gastric artery, common hepatic artery, 7th and the 8th. 9th is basically at the origin of the celiac trunk. 10th is basically at the splenic hilum. 11th is basically along this particular splenic artery. Okay, so I hope you have understood. These are the lymph node stations which you basically have. Now, what are the 2 types of gastrectomy which you basically know of? Billroth type 1, Billroth type 2. What you basically do in the Billroth type 1, you basically cut the stomach and all, that's fine. But you take the duodenum and you directly fix it onto the stomach. So this is what is called as a gastroduodenostomy. Okay, gastroduodenostomy is the type 1 Billroth procedure. What about the type 2 Billroth procedure? Here what you basically do is that you have the stomach, you have cut the stomach, that's fine. But what you basically do is you take the loop of the jejunum and then you basically perform a gastrojejunectomy. So this is what is called as a loop gastrojejunostomy. So type 2 gastrectomy is basically the loop gastrojejunostomy. Now, we will not be talking about all the complications of this, but this is something which is very important. Dumping syndrome. What on earth is this particular dumping syndrome? So what happens is that they'll give you the clinical scenario. Okay. So first of all, let's kind of state the facts, and then I'll spend, let's say, 2 minutes to kind of explain it to you. So what about the early dumping syndrome? In the early dumping syndrome, what happens is that the patients basically immediately after eating food, let's say around 30-45 minutes or something like that, patients are basically going to have an osmotic diarrhea, and because of this, the patients are going to have a state of dehydration. Why this is happening, I'll explain to you. Just give me a minute. For about the late dumping syndrome, this is going to present 2 to 3 years after eating food. Okay, after eating food. Why this is happening? Because so here what is happening, that the patients are basically going to have signs and symptoms of hypoglycemia. What do you understand by that? That the patients might undergo convulsions, patients might have a lot of sweating and all those particular stuff. And yeah, this is why, because of the relative excess of the insulin. Now, from where the hell this particular excess of the insulin came? So please try to understand over here. In you and me, what we have a pylorus. Okay, so the pylorus is basically like a gatekeeper. It is basically allowing the limited amount of whatever the food from the stomach to enter into the intestine and everything, right? Now, in this particular patient, what is happening, that you have cut that particular pylorus. So what is there? There's no kind of restriction to that particular flow. So that hyperosmotic chyme is directly entering from the stomach into the intestine. Now, whenever this hyperosmotic, I'm pretty sure you read it in your physiology, that the chyme is basically hyperosmotic. Okay, so if at all you have this particular hyperosmotic chyme, which is okay, am I audible, guys? Am I audible? There was some technical glitch. Just give me a minute. Just give me a minute. Okay, I'm really sorry. There was small technical glitch. I don't know why. I figured it out. Anyway, so what I was trying to tell you that, yeah, in the type 1 gastric syndrome, what you need to understand is what is going to happen, that hyperosmotic time is basically kind of entering into the stomach, like whatever the intestine. So hyperosmotic, right? So what is going to happen? The lot of fluid from the blood vessels and everything, it's going to kind of pour up into the intestine. Now, because of this, lot of fluid is basically pouring up into the intestine. What is going to happen is that the peristalsis of the intestine is going to increase, and because of that, the patients are going to have a osmotic diarrhea, because it's a hyperosmotic chyme. Now, what you need to understand, when this particular particular hyperosmotic chyme is entering into whatever the intestine, what you need to understand is that there are some receptors which are going to go to the pancreas, and they're going to wake up the pancreas. Wake up such amount of hyperosmotic chyme has entered into the intestine. It is going to get absorbed. So you better kind of secrete the insulin. So what happens is the pancreas basically secretes a lot of insulin, but is that particular hyperosmotic chyme getting absorbed? No, not really. It is basically flushed into the osmotic diarrhea. So what is going to happen? Over a period of time, the pancreas has produced a lot of insulin, but the kind of the glucose did not get absorbed, and because of this, there is a relative excess of the insulin, and because of this, the patients land up into hypoglycemia. Now, actually exactly like this doesn't happen, but I hope you have understood. This will help you remember what is the type 1 and the type 2 dumping syndrome. Very important. The clinical scenarios around this are asked pretty like a lot of times. Okay, so I hope you have understood this particular point, guys. Okay, now let's move on. So what is this? This is not a brain of any particular person. This is what is a mini-trias disease. So what is this basically called as? So yeah, so this is basically the protein losing enteropathy, brain-like cerebriform appearance of the stomach. Okay, so this is what is your mini-trias disease. Very important. It is basically a risk factor for the development of your gastric carcinoma as well. So why does this particular thing happen? Excess production of the TGF-alpha. So there's a lot of mucus secretion, and because of this, what is going to happen? There's a lot of what you call as a protein loss as well. So there's a pre-malignant condition, as I just told you. Stomach looks like brain and everything. That's all fine. What is this? So I'll just give you a clinical scenario. Very important. There's a patient who presented with the hematemesis. What you did was you did an upper GI endoscopy. After doing an upper GI endoscopy, what you found was this. Okay, so you expected that when there would be some very nasty ulcer, and because of that there's going to be a lot of bleeding or something like that. But what actually you basically found was that the mucosa of the stomach was actually kind of normal, but there was one particular source or one particular point from where the bleeding was basically coming. So what is this? This is what is called as a Dieule-Foy's lesion. So what is this? This is what is a Dieule-Foy's lesion. Very important clinical scenario. I'll repeat it. On the upper GI endoscopy, there's no ulcer. The mucosa is basically normal, but from this one particular point source, there's a bleeding which is basically coming out. So this is what is referred to as your Dieule-Foy's lesion. Very important. Okay. Now, what is this? This is what is your watermelon stomach. So this is what is your gastric antral vascular ectasia, GAVE, gastric antral vascular ectasia. Okay, right? So this is what you need to understand over here. Again, you have to kind of what is the management of this? So you first go and apply the clip. If not, then you basically try to kind of coagulate it. If not, then you have to perform a wedge resection. So that is the management of this duolephoid lesion. Very, very important. Okay. What about this gastric-enteral kind of vascular ectasia? Here you can basically perform a argan photocoagulation. Okay. So the argan photocoagulation is the management of this gastric-enteral vascular ectasia. Then dural atresia. I'm pretty sure all of you guys know that. But if at all in the exam, if you get this particular double bubble appearance, don't kind of jump and directly mark it as a dural atresia. If at all they have given you the dural atresia and the annular pancreas both in the options, you have to kind of look at the type of the vomiting. If at all they're giving a bilious vomiting, then probably they want you to mark it as a dural atresia. But if at all they have given you a non-bilious vomiting, then probably they want you to mark it as a annular pancreas. So please kind of take note of this. Don't kind of have a knee-jerk response and make a very, very simple question wrong. Okay, now what is this particular Meckel's diverticulum? Meckel's diverticulum is basically a true diverticulum. So what happens over here? All the 3 layers of the intestine are basically kind of dilated. That's all fine. Now, what is the cause of this? Persistent of the vitreointestinal duct and everything. Okay, now what about the clinical features? So most common presentation overall and the children is basically the bleeding and everything. Most common presentation in the adults is basically what you call as an intestinal obstruction. Okay, now why does the bleeding occur? Because there is an ectopic rest. Now what is an ectopic rest which is present over here? Yes, the most common tissue as an ectopic rest which is basically present over here is a gastric tissue. But along with that, what is this? Okay, so if I ask you what is the second most common ectopic tissue which is basically present over here, it is the pancreas. Please remember this point. Okay, so this has been asked to you. Okay, so in the Meckel's diverticulum, the 2 most important kind of ectopic tissues which are present is most common is gastric, second most common is the pancreatic tissue. Very, very important. Okay, now if at all there is a gastric tissue, it is going to kind of produce an HCl, it's going to kind of cause the erosion of the mucosa. Because of that, the bleeding is going to happen. Investigation of choice, if at all there is an active bleeding, then it is going to be the technetium 99 labeled RBC scan. Very, very important. Okay, what about the management? Okay, so okay, now for the management, what you need to understand, you have to look at the the language of that particular options or something like that, because Lovenbilly and Sebastian basically say a different things. Okay, so what you need to understand, there's a consensus that if at all there is some ectopic tissue, you try to feel that particular stuff, but if at all there is some ectopic tissue, definitely you have to kind of perform an excision. If at all the base of that particular diverticulum is involved, okay, so for example, if at all this is a diverticulum and if at all this particular base is involved, then you cannot perform just a diverticulectomy. Then you'll have to perform a resection anastomosis. You have to resect that particular intestine and then you'll have to perform an anastomosis or something like that. You understand my point? But if at all they have not given you that the base is, if at all there is an incidentally detected Meckel's diverticulum, then what you do? So then you'll have to look at the what you call as the language of that particular question. If they are saying that it is a long diverticulum with a what you call as a narrow kind of mouth, then you have to perform diverticulectomy. If they say that there is a broad diverticulum, like there's a short diverticulum with a broad kind of mouth, then probably you can kind of leave it like that. So this has been written in Lovenbilly. Please try to understand this particular stuff. Ectopic tissue present, definitely kind of excision. If at all the base is involved, definitely you have to go ahead with a what you call as a resection anastomosis. But if at all there is an incidentally detected diverticulum, long diverticulum with the kind of a short mouth, resected, short diverticulum with a wide mouth, then what you have to basically perform is what you call as a, you can just leave it like that. Okay, so that's what you need to understand over here. Okay, now what is the most common site of the carcinoid tumor in the intestine? It is an appendix. What is the management of if at all there is an appendicular carcinoid? If at all it is more than 2 centimeters, then you'll have to perform a right hemicolectomy. If at all it is less than 1 centimeters, you can just kind of do an appendectomy, and that is kind of more than enough. But if at all the size of that particular carcinoid tumor is between 1 to 2 centimeters, then you'll have to look at 2 things. What is the location, whether it is located at the tip of the appendix or whether it is located at the base of the appendix. Second thing which you'll have to see is whether the mesoappendix is involved or not. So if at all it is basically present at the base of the appendix, or if at all the mesoappendix is involved, then in that particular scenario, you'll have to perform a right hemicolectomy. But if at all it is present at the tip of the appendix or the mesoappendix is not involved, then in that particular scenario, simple appendectomy is kind of enough. Okay, so I hope you have understood this point. More than 2 centimeters, right hemicolectomy. Less than 1 centimeters, only appendectomy is kind of enough. 1 to 2 centimeters, I just explained you. If present at the base or the mesoappendix is involved, then you perform a right hemicolectomy. What about the intestinal obstruction? The most common cause of the small bowel obstruction is your adhesions, and the most common cause of the large bowel obstruction is your carcinomas. Okay, so most commonly the left-sided carcinomas. Okay, so the carcinomas of the sigmoid and the descending colon and everything. Okay, right. Now, what you need to understand, this is just to tell you the pathogenesis of small intestinal obstruction. What you need to understand, how will the patients of a small bowel obstruction come to you? Vomiting, bilious vomiting, there's going to be the dehydration, there's going to be the electrolyte imbalance. And if at all you don't kind of manage the patients early, you don't put the nasogastric tube, you don't kind of relieve the obstruction, over a period of time, the wall of the intestine is going to have the necrosis and it is going to kind of perforate. So these are the things which you need to understand over here. Now, what you need to understand is the intestinal obstruction can be of two types, dynamic and adynamic. What do you understand by the dynamic obstruction? Dynamic means that there is some kind of a mechanical obstruction which is basically present. Okay, so if at all there is a mechanical obstruction present, that is what is a dynamic. What is an adynamic? Adynamic basically means that there is a loss of peristalsis. The peristalsis is kind of not there. That is what is an adynamic obstruction. Okay, I hope you have understood this particular point, right? Okay, now if at all there is a dynamic obstruction, there's going to be an increased peristalsis. Okay, so hyperperistalsis, which you basically see on the auscultation, that is because of the dynamic obstruction. And in the dynamic obstruction, you basically get a colic abdominal pain. Adynamic obstruction, you basically get a dull aching pain. Okay, dull aching or the no pain at all. And yeah, so absence of the peristalsis. If at all I give you a scenario where I tell you that there is a patient who started with a colic abdominal pain and there was an increased peristalsis and auscultation and everything, but now the patient has basically that particular colic abdominal pain has converted into the dull aching pain and the peristalsis are no more audible, then what do you infer out of it? You basically infer out of it that the bowel is basically undergoing necrosis. Are you understanding my point? So you have already kind of been very late in managing these particular patients, and now the like in the like dynamic or the physical obstruction wala patient, what is happening is that the intestine is basically undergoing necrosis and everything like that. Okay, I hope you are able to understand this particular point. Very, very important. Okay, now these are the x-rays which you need to understand. Air fluid levels, very, very simple. Obviously you would have read it for like so many times, but yeah, even this is basically an x-ray which is basically trying to show you about the small intestinal obstruction. What is this? This is what is a step ladder pattern. The another important thing is a valvulae conniventus. Okay, so if at all there is a valvulae conniventus present in these particular x-rays, okay, so what you need to understand is that it is basically indicating that it is a distal obstruction. It is not an obstruction at the level of the duodenum or anything like that. It is basically obstruction at the level of the jejunum ileum or something like that. Okay, right? I hope you have understood. Now, obviously, if at all there is a dynamic obstruction, you'll have to kind of go ahead with the surgery early, because otherwise the bowel will undergo necrosis and everything. But if at all there is an adynamic obstruction, which is basically referred to as your paralytic ileus. So if at all there is a paralytic ileus, which you basically have, you have to perform three things. What are the three things? Give the IV fluid resuscitation, because the patients will be at the dehydrated, right? At the end of the day, the patient is basically having an obstruction. You put it in your gastric tube because you want to decompress the abdomen. If you don't do that, the bowels will undergo necrosis. And electrolyte correction, because the most common cause of a paralytic ileus is hypokalemia in the post-operative patients because of the lack of the potassium. That is what is the most common cause of your what you call as your paralytic ileus. Okay, so I hope you have understood this particular point. Very, very important. Okay, now another small concept which you need to understand is something which is called as an open obstruction and the closed obstruction. So the small intestinal obstructions are usually the open obstruction because there's no kind of a or like from the upper side they are kind of open. But in the large bowel obstruction, what you need to understand is that there is a ileocecal valve and there is whatever like that is kind of a valve which is present. And let's assume that in the transverse colon or the descending colon or something like that, if at all there is an obstruction, that basically becomes a closed loop obstruction, and in that the chance of the necrosis and the gangrene and the perforation are much higher. Okay, that's why they need more like early surgery is kind of needed in the large bowel obstruction. What is an intussusception? A part of the intestine is basically telescoping into the other. That is what is an intussusception. Again, the child is like more common in the children. The patients are going to come to you with a colic abdominal pain and everything. Colic abdominal pain, bilious vomiting, all those the same kind of features are going to be there of any dynamic obstruction. Now, the important is this particular imaging and everything. So, what is this? What is this? This is an ultrasound. What are you basically seeing on the ultrasound? This is what is called as a pseudo kidney sign. So, this is not an ultrasound of a kidney, right? It's not like a, does it look like a kidney? Yeah, it looks like a kidney, right? But it is a pseudo kidney sign, what you need to understand over here. So let's assume that there is a intussusception which is present, and if at all you have an ultrasound probe, if you keep it along along the length of the intestine, you are going to have this particular pseudo kidney sign. But if at all you get it, let's say perpendicular, like 90 degrees to that particular length of the intestine, then you are going to have this double target sign or the donut sign or whatever you want to call it. Okay, so double target sign, donut sign, whatever you want to call it, you call it. Okay. Now, what is this? This is what is a claw sign, which you basically get on the barium enema. So on the ultrasound, you get a pseudokidney sign or the target sign. On the barium enema, you get a claw sign. You also get a coiled spring appearance. I don't have an image of that, but once they had asked you. So remember, coiled spring appearance is also what you basically get on the barium enema. And then on the plain X-ray, what are you going to get is an air crescent sign. So all these particular signs are important. I'm pretty sure you guys know that. Also, be vigilant about the imagings of that. Okay, so whenever you have a patient with an intussusception, what you basically do is you try to reduce it. You first try it with the air enema. If that helps, that's great. Otherwise, you can go ahead with a gastrographin enema as well. Gastrographin enema. Okay, why? Because again, that is a hyperosmotic kind of a contrast. So it is going to kind of bring in water and everything. So because of that, it will help you reduce that particular intussusception. But the prerequisite for performing this particular whatever the reduction of the intussusception is that the perforation should not be present, peritonitis should not be present. If at all the perforation is already present, if at all the peritonitis is already present, in that particular scenario, you'll have to directly go ahead with the surgery. That is what you need to understand. Now, what about the sigmoid volvulus? What is a volvulus? Volvulus is basically that any particular part is basically rotating on its own axis. Now, in the sigmoid volvulus, what happens is that there's a sigmoid colon which is basically rotating on its own axis, right? Now, how it's going to kind of rotate? If at all there is a superly loaded colon, okay? So obviously that's going to be one of the reasons, and it's not the broad-based mesentery, it is the narrow-based mesentery, okay? So what you need to understand is that if at all the mesentery is very, very narrow, so what is going to happen? It's going to act as a pivot point, and over the period of time, that particular mesentery can twist on itself. For example, let's assume ovarian torsion, okay? So when does it occur? If at all the ovarian cyst is very, very big, let's say 7, 8, 9, 10 centimeters, there's a risk of ovarian torsion. Why? Because now this particular long, big cyst is basically attached to the whatever the uterus with that particular small stalk. Okay, I hope you're understanding this particular point. Now, I'm pretty sure you have seen this particular X-ray thousands of times. What is this? This is what is a coffee bean appearance on a inner bent tube sign. Okay, so the coffee bean appearance or the inner bent tube sign, this is what is an X-ray for your what you call as a sigmoid volvulus. So what is the management of this sigmoid volvulus? The management of the sigmoid volvulus is basically what you call as, what is the management of the sigmoid volvulus? So management of the sigmoid volvulus is what you refer to as your what is it? Yeah, so sigmoidoscopic derotation and everything, but if not, then you have to perform a surgery, like open surgery and everything. That's all fine. Okay, so do not forget that particular X-ray. That's very, very important. Now, one thing if you want to remember on the cecal volvulus, that is what is a comma-shaped appearance. Okay, so what you basically get in the cecal volvulus is a comma-shaped appearance. In the sigmoid volvulus, what you basically get is coffee bean appearance or whatever, the inner bent tube sign or something like that. Now, colonic diverticulum, again, it's a very, very important topic. So let's kind of quickly talk about it. What is this? Is it like a true or the false diverticulum? It is a false diverticulum. So what happens over here? The patients are basically having, let's say, chronic constipation or something like that. Because of this, what is going to happen? There's going to be an increased pressure inside whatever the colon, and because of this, what is going to happen? The mucosa will basically pop out. From where the hell this particular mucosa is going to get pop out? So what you need to understand is that there is a wall of the colon, right? And with this, okay, so I'll just kind of enlarge this. What you need to understand is this is the mesentery. Okay, so this is a mesentery from where this particular blood vessels are coming, and they are basically going around that particular whatever the lumen of the bowel, and at one point of time, at one point they are going to pierce through that particular bowel, and they're going to enter, and then they're going to supply the inner part of the bowel, like whatever the muscle and all those particular stuff, right? Now these particular parts become the sites of a potential weakness. So whenever there is an increase in the pressure inside whatever the colon or something like that, what is going to happen? The mucosa will find it a bit easier to kind of go through these potential weaknesses. You understand my point? So this is what is referred to as your colonic diverticulum, pulsion diverticulum. It is not a traction, it's a pulsion diverticulum. Mucosa is basically coming out. It is what is a false diverticulum. Okay, now the presence of a diverticulum is called as a diverticulosis. Now, in that particular diverticulum, some complications can happen. What are the complications which can happen? Bleeding can happen, and the diverticulitis can happen. Bleeding, why? I'm pretty sure that now you understand that there's so much in contact with the blood vessels, right? So they're basically going rather through the same channel. So obviously the bleeding can happen. Now, overall, the diverticulum are more common on the right side of the colon or the left side of the colon. They're more common on the left side of the colon. But if at all the diverticulum is on the right side of the colon, the chances of the bleeding are more. Overall, sigmoid colon is the most common site of your diverticulum. Okay, I hope you have understood this particular point, guys. Okay, now the complication, as I told you, bleeding, we just talked about diverticulitis. So that particular diverticulum can get ruptured, and there can be a localized inflammation because fecal matter might kind of go, inflammation can happen. That is what is called as a diverticulitis. Now, if I ask you that what is the investigation of choice for the diverticulosis, it is going to be the barium enema. The characteristic appearance which you're basically going to get is just sawtooth appearance. Okay, the sawtooth appearance is basically what you get in the barium enema and the diverticulosis. In the diverticulitis, barium enema is not performed. It is kind of contraindicated. So investigation of choice for the diverticulitis is your CT scan. I hope you have understood this particular point. Diverticulosis, investigation of choice is barium enema. Diverticulitis, the investigation of choice is your contrast and CT scan. Okay, so I hope you have understood this particular point, guys. Okay, now overall, if you talk about the diverticulitis, what is the most common complication of the diverticulitis? It is fistula formation, okay? And what is the most common fistula which is getting formed? Colovesical fistula. Colovesical. Why so? Because the sigmoid colon is very much kind of near to the pelvis, and if at all, let's say the bladder fills up, what is going to happen? That bladder is going to get adhered to that particular inflamed diverticulum. Now you give the antibiotics and everything, that particular inflammation basically goes down, that diverticulum basically heals, and over a period of time, what happens? There is a fistulous communication between this particular urinary bladder and the colon. Okay, so this is what is called as a colovesical fistula. Okay, so there's a fistulous communication which is kind of established between these particular stuff. Okay, so this is what you need to understand over here. Diverticulitis, the most common complication is what you refer to as a fistula, and what is the most common fistula, which is basically called your colovesical fistula. Now, there's something which is called the Hinch's classification. So, where have you ever heard of Haggett's classification? Haggett's classification is for what? It is for the colorectal polyps. Okay, polyps. After polypectomy, what you basically get is a Haggett's classification. What is this? This is what is the Hinch's classification. So, what is this particular Hinch's classification? Hinch's classification is basically, yeah, it is for the diverticulitis. So, complications of the diverticulitis. So, if at all there is a pericolic abscess just around the colon, if at all there is an okay. Really sorry, guys. Yeah, am I audible? Am I audible? Or I have always been audible? Okay, right. I hope I'm audible. Yep. Please let me know, guys. Yeah, okay, sorry. So what I was trying to talk to you about, so Hinch's classification. What is this particular Hinch's classification? What you need to understand, in a type 1, there is a pericolic abscess just around the colon. If at all there is an abscess formation, that is what is a pericolic abscess. That's fine. Then the type 2 is basically the pelvic abscess, that there's a abscess in the pelvic cavity. That's fine. Then what we have a type 3. Type 3 is a purulent peritonitis. There is a pus in the peritoneum. That's fine. What about the type 4? It is a feculent peritonitis. So please remember, it's very simple, nothing. It's logical. Around the colon, if at all there is an kind of abscess, pericolic abscess. If at all in the pelvis there is an abscess, that is what is a pelvic abscess. If at all there is a purulent peritonitis, pus in the whatever the peritoneum, that is what is a purulent peritonitis. And if at all there is a fecal matter inside the peritoneum, that is a feculent peritonitis. So Hinch's classification 1, 2, 3, 4. Haggett's is basically for the polyps. Okay, to see whether the malignancy is basically present inside the polyp or not. So that is after the polypectomy. What you basically get is a Haggett's classification. Okay, now let's not talk about all this particular stuff like the management of the diverticulitis. It's okay, nothing major about this. Now, the polyps of the large intestine, there can be benign and the malignant and everything. So hyperplastic is there. Then we have a hamartomatous, juvenile, and the Peutz-Jeghers. So what is the characteristic about the juvenile? The clinical scenario which they're going to give you is, usually they give, let's say, 4-5 years or something like that. 4-5-year-old child has been brought to you with the bleeding. You do a proctoscopic examination. What you find is a solitary polyp. A single polyp is kind of present over here. What is the diagnosis? The diagnosis is juvenile polyp. What is the management of that? You just do a polypectomy. That's it. Nothing major. So sigmoidoscopic polypectomy. That is what is the management of the juvenile polyp. Benign polyp, nothing to be done. Peutz-Jeghers polyp. What is this particular Peutz-Jeghers polyp? So that's all fine. The important thing in this, what they're going to give is, okay, they're going to have the polyps and everything. That's fine. Along with that, they're going to have a, what you call as a hypermelanotic macules in the mucosa of the oral cavity. Very, very important. Okay, hypermelanotic macules in the mucosa of the oral cavity, Peutz-Jeghers syndrome, along with the polyps. Okay, inflammatory. So what is this inflammatory? So this is like the ulcerative colitis, pseudopolyps and everything, right? Here the polyps per se are not malignant, but what it causes the underlying intestine becomes kind of pre-malignant. So polyps are benign, but because of the ulcerative colitis, the disease per se, what is going to happen, that the underlying intestine is going to be kind of precancerous. That's what you need to understand. Ulcerative colitis can lead to a colorectal cancer, right? Then we have a tubular villus and the tubular villus. These are the malignant kind of things. We've talked about this particular Peutz-Jeghers syndrome. So what you need to understand, the Peutz-Jeghers syndrome is a benign condition for the colorectal polyp. Like, it's not a kind of malignancy. It is not a risk factor for the malignancy of the colorectal. But what you need to understand is that it is a very, 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 very important risk factor for your pancreatic cancer. So what is the kind of mutation which is present over here? LKB1 or the STK11. So STK11 gene mutation Peutz-Jeghers syndrome, it basically has a 100-fold increased risk of the pancreatic cancer. Very, very important over here. Okay, so please remember, but it is not going to increase the risk of your colorectal malignancies. It basically increases the risk of extraintestinal malignancies. Now, out of this villus tubular and everything, villus is the one which is more likely to be malignant. So if at all there is a polyp which is villus type more than 2 centimeters, and if it is sessile, it means that what you call as the polyp is basically not having any particular stalk. In this particular scenario, the risk of the malignancy is going to be more. Now, there are two syndromes which you need to understand over here: familial adenomatous polyposis and the HNPCC. So, what is this particular familial adenomatous polyposis? This is basically caused by the genetic mutation, APC gene mutation. This is what is basically present at the 5q21 gene. Okay. Now, in this particular familial adenomatous polyposis, what you basically have is more than 100 polyps are there. Okay, more than 100 polyps. And if at all there is a patient, let's assume that somebody assume that I have a FAP kind of a gene, FAP syndrome, and if I have this particular APC gene mutation, there's a 100% chance that I'm going to get a colorectal malignancy in my life. So by, let's say, around 30 years, 40 years or something like that, I'm definitely going to land up into colorectal malignancies. Okay. Now, is it a very, very important risk? Like, if is it a very, very important contribution to the colorectal malignancy? Probably not. Only 1% of all the colorectal malignancies are going to be associated with the FAP syndrome. But if at all there is a patient who is having FAP syndrome, 110% that particular person is going to have a colorectal malignancy. That is what you need to understand over here, right? So if at all I tell you that, you know what, I have 100% chance of getting a colorectal malignancy, what are you going to tell me? Go and get a surgery done. Okay, which surgery I should get it done? I should get a total colectomy. That's going to be enough? No. So I have to get a total proctocolectomy. Even the rectum has to be removed. Okay, because the risk factors for the colorectal malignancies are the same. Okay, so what is the name of the surgery which you basically perform in the FAP syndrome? Total proctocolectomy. Rectum as well as the colon is removed. And now what? Whatever I eat, where the hell it's going to go? So now what you have to do is you have to perform this IPAA. What is this IPAA? This is what you refer to as a ileal pouch anal anastomosis. IPAA is ileal pouch anal anastomosis. So what you basically do is that this is the intestine which you basically have, small intestine. So what you basically do is you convert this particular small intestine into a pouch. Okay, so you basically convert the small intestine into a pouch and then you attach it to the rectum. Are you understand my point? So this is what is referred to as your ileal pouch anal anastomosis. So what is this? This is what is your ileal pouch anal anastomosis, which you basically perform in the patients with the FAP syndrome. I hope you have understood this particular point. Now, what is this HNPCC? HNPCC is hereditary non-polyposis colon cancer. Now, in this also there is a risk of the malignancy and everything, but what you need to understand is that there is an 80% risk of malignancy. What is this? There is an 80% risk of malignancy. It means that if at all there is a person, if at all, let's say I am having this particular HNPCC gene mutation, there is an 80% chance that I'm going to have a colorectal malignancy. So will you advise me a prophylactic surgery over here? The answer is no. You will. So prophylactic surgery is not done in the HNPCC. What you basically do is you put the patients on surveillance. Out of all the colorectal malignancies, how many of them are contributed by this HNPCC? 5%. In the FAP syndrome, out of all, only 1% was contributed by the FAP syndrome. Out of all, 5% is basically contributed by the HNPCC. But still, in the HNPCC, you do not advise the patients to undergo a prophylactic surgery. Why? Because the risk of developing a malignancy, if at all that particular individual is having the HNPCC syndrome, is only 80%. Okay, so what you basically do is you put the patients on surveillance. You basically ask the patients to kind of come, let's say practically annually, you perform this particular colonoscopy, and if at all you find some polyp, what you basically do is you do a polypectomy. After that, what you do is you send it for the pathologist. So pathologist basically tells you that, okay, what grade of that particular Haggett's classification is there. So if at all there is a Haggett's type 4, okay, if at all, so this has basically a bit trivia kind of thing, I'll let you know. So if at all there's a Haggett's type 4, definitely the surgery is needed. Okay, so let's forget about the grades of the Haggett's and everything, but let's try to understand if at all the surgery is needed. What is the surgery which you're going to kind of advise in the patients with an HNPCC syndrome? It is a total colectomy. Here the rectum you kind of leave behind. So after doing the surgery, can you tell the patient that, you know what, I've removed the colon, everything is fine? No, not really. There is still a chance that the patients might land up into whatever the rectal kind of malignancy, and that is why you have to advise the patients to continue with the proctoscopic examination. Okay, so here what is the management of this? total colectomy with iliorectal anastomosis. Now, why on earth we chose the iliorectal anastomosis over here? On the other hand, in the FAP syndrome, we chose an ileal pouch anal anastomosis. The reason was that in the FAP syndrome, if we would have left behind the rectum, definitely the malignancy would have developed. And why we did not do an ileal pouch anal anastomosis over here? Because that is a more complex surgery with more comorbidities and everything. So here we can take a bit of a risk because there is a 20% chance that the malignancy will not develop, right? And we always have an option of continuing with the proctoscopic examination. So I've just gone into a bit of a concepts over here. I hope you have understood. I'm pretty sure that you guys knew this. I hope this helped you revise or something like that. I'll just summarize it once more. FAP syndrome, APC gene mutation, 5q21 gene mutation, and what you need to understand. 100% risk of malignancy, and that is why you have to perform a total proctocolectomy with ileal pouch anal anastomosis. On the other hand, in the HNPCC syndrome, what you need to understand is there's a mismatch repair gene and everything, that's fine. There is only 80% risk of malignancy, and that is why you put the patients on surveillance. If at all there is a higher Haggards grade, Haggards 4, then what you have to perform is a total colectomy with iliorectal anastomosis, but you have to advise the patients that, you know what, continue with the proctoscopic examination over a period of time. Now, HNPCC syndrome is also referred to as the Lynch syndrome. So they are synonymous. They are not different from each other. HNPCC is basically the Lynch syndrome. So we have a Lynch 1 and the Lynch 2. What is this Lynch 1? Lynch 1 is that there is only the colorectal malignancy. What about the Lynch 2? Lynch 2 is along with the colorectal malignancy, the patients are also having the risk of extraintestinal malignancies like the ovarian or the endometrial or something like that. Okay. So these are the things which you need to understand over here. Then there is a modified Amsterdam criteria, Bethesda criteria. Let's not go into the details of that. Okay. Now, okay, so colorectal malignancies, all these other risk factors we just talked about and everything. What is the most common site of the colorectal malignancy? Sigmoid colon, sigmoid colon. Now, all you need to understand is the basic difference between the right and the left side of the colon. They simple, but they ask the clinical based scenarios over here. What you need to understand, on the right side, that is the ascending part of the colon, you have a predominantly ulcerative lesion. Because of this, what you have, there is a occult bleeding which is basically taking place, and because of this, these particular patients, they present with what you refer to as anemia. Okay, so anemia or the whatever the mass in the right iliac fossa. This is how the right sided colorectal malignancies are going to present. What about the left sided colorectal malignancies? Left sided colorectal malignancies, what they have, they are predominantly what you call as a infiltrative. They are predominantly infiltrative, and that is why they present with the intestinal obstruction. Okay, so the left-sided colorectal malignancies predominantly present with intestinal obstruction. Right-sided colorectal malignancies predominantly present with anemia because of some amount of occult bleeding which basically takes place, and that is why in order to screen the patients for the colorectal malignancies, what we do is fecal occult blood. That is the reason for that. I hope you have understood this particular point, guys. Okay, right. So all these particular things are fine. Let's not go into the management. Last thing which I want to cover is about this particular Fistula-in-ano. So again, obviously I've not covered everything, but this is something which I think that I should cover with you guys. So what is this particular image I'm trying to show you with? This is what is the seton. Now, what on this is this particular seton? Seton is basically a what do you call as a inert kind of a thread kind of a thing which you basically pass through this particular Fistula-in-ano. So what I'll do is, investigation of choice for the Fistula-in-ano, it is basically MRI. Please try to understand this. It's not fistulogram, it is not your Goodsall's rule and everything. Investigation of choice is your MRI. That is going to give you all the information you need. What are the number of fistulas, whether it's a simple fistula, complex fistula, what is an external opening, internal opening, everything is going to kind of give you, right? That's the first thing. Second thing about the management. So what is the treatment of choice for the Fistula-in-ano? It is a fistulotomy. It is not a fistulectomy. Okay, you cannot cut the fistula and throw it off. You cannot kind of do that. What you have to do is you have to kind of open the fistula like this. Okay, so let's assume that this particular tract is not healing. What we do is we surgically go to that particular tract and then we kind of open that particular fistula like this. And now it basically becomes like an open wound, and over a period of time it is going to kind of heal up. Okay, but the problem is, let's assume that there is a complex fistula, or let's say there is a high fistula. So you have done the surgery, that's fine. But what's going to happen over a period of time, once the healing takes place, maybe the sphincter will not kind of recover in a good manner, and because of this, what is going to happen, the patients will be incontinent. So obviously that is not a that will not solve your purpose. That is the first thing. Second thing, what you need to understand is, let's assume that there is a patient in whom you're dealing with a patient who is immunocompromised. The patient is basically having AIDS, or patient is grossly immunocompromised. In that particular scenario, what you're going to do? So in that particular scenario, if you perform this fistulotomy, you will do the surgery, that's fine, but the healing process will be very much delayed and it will not be proper. So these are the two indications where you basically use the seton. Now the seton can be of two types. It can be simple draining seton or it can be a cutting seton. Draining seton is basically used whenever you have an infection. So if at all they give you that there is a fistula and from there what you understand is a lot of pus is basically coming out, when you press it, a pus came out and all those particular stuff, the management is draining seton. You put the draining seton, it's going to, you give the antibiotics, you give wash and everything through this particular seton. So what is going to happen is that that particular, whatever the infection and the pus and everything will be taken care of. But if they ask you the management, if at all they give you that there is a patient who is HIV positive, immunocompromised, the patient is basically having the Fistula-in-ano, what is it management or the treatment of choice? That is what is going to be the cutting seton. Now how this particular cutting seton works, you put this particular thread, you leave it there, then you call the patient after 1 week, then you tighten up, then you send the patient back, you call the patient again after a couple of weeks, then you again tighten up. So what is going to happen, every time you basically tighten this particular seton, what's going to happen, some small portion of that particular sphincter is basically getting cut. And why you basically wait for a couple of weeks before you cut that particular thread again? Because you want to allow that particular tissue to time to for that particular tissue to heal, or like above that particular seton, you want to allow that particular tissue to kind of heal. I hope you're able to understand this particular point, guys. Okay, so that is how you kind of manage a cutting seton. So simple fistula-in-ano, what is the treatment of choice? Fistulotomy. Immunocompromised patients, what is the treatment? Cutting seton. If at all you have what you call as a high fistula or complex fistula, something like that, in that also you can perform this cutting seton. If at all there is a evidently pus coming out of that particular fistula-in-ano, what you basically put is a draining seton. Okay. Now last thing, what is it? Okay, this is kind of done. Fistula-in-ano. What is the treatment of choice for the anal cancer? Chemoradiation, not surgery, right? Okay, please do remember, treatment of choice for your anal cancer is chemoradiation. Okay, so yeah, that's all I wanted to cover. I'm really sorry for the delay. I hope this particular thing helps you at least a bit in your whatever exam or something like that. Thank you so much for kind of attending it a couple of days before the exam. I know that I could have done these particular things quite early, let's say 15, 20, 30 days early, but yeah, it's better late than never or something like that. I will not take a lot of time of you guys. I'll kind of talk about all these things later. First of all the best. I hope you are going to do very well in your exam and something like that. I'll not take a lot of your time because I know everybody is trying to kind of give you that, you know, do well, motivation, all those particular stuff. I'll not kind of do that. Your time is very precious, so thank you so much for giving, let's say, your time to me for attending this particular session. That's the first thing. Second thing is, guys, it's your day. Okay, so I'll just cover my 2 bits and you can see if at all it resonates with you, you can kind of go ahead and do that. Okay, so what you need to understand, first of all, okay, anxiety is kind of normal. We all are human beings. We are going to feel that particular pressure, the pain and all those particular things. We are going to kind of feel that. That's what's going to make you a better person when this particular exam is going to over. You will not even realize it, but you will come out stronger after this particular exam is going to get over. Doesn't matter whether you kind of succeed gloriously or if at all you fail very visibly, you are going to come out as a slightly different person after this particular exam. So that is first thing which you need to understand over here. And it's your day, right? Now still the ball is in your court. So I'm pretty sure that all of you might not be at the same level of preparation. That's all fine, but whatever you have read, right, whatever you have read, obviously you would have read, right, some would have read a bit more, some would have read a bit less, but whatever you have read, please try to kind of do justice to it on the day of the exam. Keep your cool, don't kind of stress, like, do stress but don't over stress, because over stress becomes counterproductive. On the day of the exam, just kind of focus on that particular part. So whenever you are on one particular question, give your 100% to that particular question. Be fast. I'm not trying to kind of asking you to be slow, but be present in that particular situation. Don't assume things. Try to kind of read properly what the examiner is asking. Many times we tend to omit, except many times we have a knee-jerk response. We say that, oh, this is such a simple question, I know, and you mark and you move ahead, and then you will not get a time. The thing with the physical papers is that you can just kind of rotate the papers and you can go back to that particular question. With the whatever this particular computer based exams, you do have a option of mark and review and everything, but many times we do not end up using it very effectively. So even if you remember it later, you might find it a bit difficult. So the bottom line is that when you're on that particular question, stay focused, just give everything to that particular question. That is the first thing. Now anxiety is going to be there, frustration is going to be there, you want to curse the TNB, you want to curse everything, you do that, that's all fine. But what you need to understand is these particular things are not under your control, so it's all fine. It's whatever has happened. You travel, you just reach whatever your center, like city, one day prior or something. I'm pretty sure that many of you might be traveling, that's all fine. You take care of that, but don't, it's okay. It's okay to be angry, but that's not the time. After your exams are over, then you can do whatever you want. Okay, so at this point of time, just keep your cool. Don't get over anxious. That's fine. It's very easy for me to kind of sit here and say, but I understand. But try your best to kind of be a little bit less anxious. The best way to kind of do that is go to your inner circle, like those who are your actual well-wishers, your friends or whatever, and your family or whatever, like whoever is your actual well-wisher, just kind of go to them. And like, I'm not trying to asking you to kind of spend time with them, but just have a heart-to-heart conversation with them. That's going to give you a bit of a strength. That's the first thing. On the day of the exam, just deliver what you know, just be on the question, and yeah, that's all I would say. Nothing major. So nothing I say or nothing you do in these particular 2 days is going to change your whatever the scenario very, very drastically, but it should not worsen it up. So don't panic on the day of the exam. Don't be over anxious. That's all I would say. Okay, so all the best. I'm pretty sure that you're going to do well, and waiting to hear from you guys after your exams are over and all those particular stuff. And I'm pretty sure that you guys will kind of clear it up. And let's assume that after 1 month, 2 months or something like that, somebody's watching this particular video or something like that. And if at all you wish to connect with me, this is a QR code. You can connect with me on WhatsApp number. I'll add you to a couple of groups, my WhatsApp group, Telegram group, whatever. The number is also given in the description box below. This is basically a YouTube channel. If at all you find that it might help you or something like that, consider subscribing, and that's fine. And this is the QR code for my Instagram. Not yet active, but it's going to be active very, very soon. And yeah, that's all. I will end my session along with this. Thank you so much for your time. Have a great time. Happy studying. See you. Bye-bye. Take care. Good night.